Hello, everyone. I'm Lindsay Joseph, and I'm the LINKS Program Officer, and I'd like to welcome you all to the February LINKS webinar. Before we begin, I'd like to share a few housekeeping rules. The lecture will be around 30 minutes long, followed by a Q&A session. We encourage participants to use the Q&A buttons to ask questions. The Q&A button is located in the bottom corner of your screen. Participants will be muted during the presentation, but will have the option to unmute themselves before the Q&A portion. This webinar is being recorded and will be posted on linkscommunity.org. Now I'll hand it over to Dr. Tom Frieden, President and CEO of Resolve to Save Lives, to introduce the topic and speaker for today's webinar.
Good morning or afternoon, everyone. Welcome to the LINKS webinar. LINKS is an online community, and it's a resource center for people working to improve cardiovascular health around the world. It's a collaboration among our Resolve to Save Lives, the World Health Organization, and the Centers for Disease Control and Prevention and its foundation. As you know, hypertension is the world's leading killer. Globally, more than 10 million people die from high blood pressure each year, more than all infectious diseases combined. Treatment of hypertension can save more lives than any other clinical intervention. And in this year of calls for universal health care, it's clear that hypertension control both requires and facilitates creation of effective primary care structures. Resolve works with global, national, and local partners to help establish and scale up proven strategies to improve the control of high blood pressure. One key aspect of a successful hypertension control program is implementation of a standardized national or state provincial level treatment protocol that is drug and dose specific and outlines steps to take if blood pressure is not controlled. Use of a standardized evidence-based protocol reduces clinical variability, makes it easier to manage procurement and logistics, and should drive down the cost of protocol medications. There's a critically important difference between a guideline and a protocol, and that difference is one of the primary changes that we believe is needed to help scale up effective management of hypertension. Today's presenters are Dr. Norm Campbell, Professor of Medicine at the University of Calgary, and Dr. Pradeep Kaur, Deputy Director and Head of Non-Communicable Disease Division at the Indian Council of Medical Research, National Institute of Epidemiology in Chennai, India. They'll discuss the protocol selection process, including advantages and disadvantages of algorithm-based hypertension care, drawing on examples including from India. I now hand it over to Dr. Norm Campbell.
Thank you so much, Tom. It's my great pleasure to be able to speak with you today. I'm going to talk about some of the concepts that are thought to really matter in choosing a best treatment protocol. Next. Lindsay, can we have the next? Thanks. One of the most important concepts is that complexity empowers specialists like myself. It allows us to identify and manage very difficult patients. However, most hypertension control is done at the primary care level, and because of the great diversity of patients that they need to see, anywhere from pediatrics, pregnancy, to complex older patients, complexity becomes very disempowering and is almost impossible to implement. So it's very important when we're talking about hypertension control at the primary care level to focus on the very few things that are important. This includes systematic screening of blood pressure for hypertension, to appropriately diagnose hypertension, to assess and intervene on associated cardiovascular risks, which are present in 90% of people with hypertension, to treat people to target, which is in general less than 140 on 90, but in specific settings less than 130 on 80. And something that's not commonly done in clinical practice currently, it's to monitor and to evaluate the performance in terms of achieving blood pressure control in the clinic population. It's very important to keep these items as simple as possible, and we'll talk specifically about treatment protocols here, but to do them correctly in all the patients and to do them routinely in all patients. Next slide. As we come to this talk, I'm going to talk about treatment protocols. Throughout much of the talk, I may refer to them as algorithms. I'll use protocol and algorithm interchangeably. It's a step-by-step set of instructions for solving a problem. The context for this talk is protocols for controlling hypertension. A fixed-dose combination, or FDC, is a tablet that contains 2 or more medications. And again, in the context of this talk, I'm going to talk about 2 or more antihypertensive medications combined, such as amlodipine and telmisartan, the drugs that are in the RESOLVE protocols. Next slide. It's very important that people understand that nearly all randomized controlled trials that examine the blood pressure lowering effectiveness of antihypertensive drugs or the use of antihypertensive drugs to prevent cardiovascular disease used very simplified diagnostic algorithms, and this is called entry criteria, and treatment algorithms. So our knowledge that antihypertensive therapy lowers death and disability and controls hypertension is largely based on very simple hypertension management algorithms, such as what we're going to talk about today. There are a few clinical trials that compared algorithms to clinicians doing their usual management. In all these circumstances that I'm aware of, the algorithm had better blood pressure lowering, improved hypertension control, and less cardiovascular events than usual individualized care. And in fact, in many of my talks, I describe usual individualized care as chaos. Next slide. Some of the concepts of what a best algorithm is that it's very simple and easy to implement in primary care. And this reflects the types of algorithms that were used in clinical trials. The best algorithms have very few to no options. The exact drugs and doses are pre-specified. The best algorithms can differ depending on the local context. And that is specific to the availability of high-quality, long-acting, affordable medications, which differ in different locations. It's very important that the best algorithms are endorsed by local primary care or hypertension experts. Otherwise, the algorithms will be undermined by these individuals who feel that there are better algorithms, or perhaps that no algorithm should be used. So this endorsement step is of great importance. However, it's very important that just as in clinical trials, that there needs to be entry criteria in the diagnostic algorithm to make sure that people are suited to be managed by the algorithm. Specifically, this means no contraindications for the chosen drugs or no indications for alternative drug therapy. This is quite important in the context of potential to become pregnant, that these individuals not be given drugs that are potentially teratogenic or that may harm the fetus. Next slide. Some of the great benefits of algorithms are reduced clinical variability. Patients are managed in similar fashions. This very simple approach allows much greater task sharing and shifting because there's less judgment involved in what the next steps are. These types of algorithms can be incorporated into quality assurance resources. This could be something like a computer record, but most often I see it as a poster on the wall of the office to make sure that people know what the right steps are when the patient presents to them. As Tom mentioned, the use of algorithms can markedly reduce therapeutic costs, and this is because the drugs can be selected to be those that are affordable in the region, and that they can be purchased in bulk. The algorithms can improve evidence-based choices of drugs and diagnostic tests because as the algorithm is being developed, it incorporates the best of drugs and diagnostic tests that are available in the region. One of the most important things is this concept of therapeutic inertia. And throughout the world, it's been observed that in clinical practice, often patients with hypertensive blood pressure readings do not have a change in their therapy. And it's believed that this is often related to uncertainty about what the next best step is. And this often results in nothing being done. Algorithms provide great clarity on the next step and tend to result in much more rapid blood pressure control. Next slide. In terms of desirable characteristics for drugs and algorithms, it's important that the selected drugs be shown to be effective at reducing blood pressure, and preferable that they've been used in randomized controlled trials showing a reduction in cardiovascular events. It's important that they be long-acting with once-a-day dosing, and this is important for patients adhering to the therapies. That there's a low rate of serious adverse effects or symptomatic adverse effects. Little to no need for laboratory monitoring. This is perceived to be very important where laboratory monitoring is not available, but we do notice even in high-income countries like Canada and the United States, laboratory monitoring is infrequent. That the drugs be inexpensive, and I would interchange this with affordable to the people who are being prescribed the drugs. That there is the ability to bulk purchase the drugs because of the very large numbers of people that require treatment. 40% of people over age 25 have hypertension, and most of these people would benefit from being treated. It's very important that some things can happen to the drugs that are in the algorithm that may make them not available or suitable to a specific patient. And so in this setting, it's important to have substitutes. And finally, I will be talking in the next few slides about fixed dose combination drugs. It's desirable that the drugs be available in a fixed dose combination tablet. Next slide. In terms of fixed dose combination drugs, it's important to recognize that about 3/4 of people with hypertension require 2 or more drugs to achieve blood pressure control. Only about 1/4 of people, and mostly people with the lower stages of hypertension, can be controlled with a single antihypertensive drug. The fixed dose combinations compared to initial drug treatment in clinical trials reduce the number of pills that a patient needs to take, and this is important for patient adherence. In clinical trials, adherence is better to fixed dose combination therapies than the single drugs in tablets. It results in greater and more rapid blood pressure control compared to the single drugs and tablets. And in observational data, results in a reduction in cardiovascular disease, and that's likely related to the greater and more rapid reduction in blood pressure and the improved adherence to therapy. When we do audits on charts, and this is in high-income countries or low-income countries, we often notice that when primary care are prescribing single drugs, they're often suboptimal combinations. And in Canada, one of the things we noticed was combining a beta blocker with an ACE inhibitor in people without a specific cardiac disease. This results in much less blood pressure lowering, and is also believed to result in less cardiovascular protection, particularly from stroke, when using fixed dose combinations, as we'll come to in the next slide. Next. The combinations are generally highly rational. They're long-acting, once-a-day medications that have additive or synergistic blood pressure lowering. And this is usually because of regulatory requirements in the country that drugs must have these characteristics in order to be combined in a single tablet. And one of the examples of a combination tablet is amlodipine with telmisartan. Most fixed-dose combinations will have a reduced side effects relative to single drug treatment, particularly at high dose. And an example of this is reduced edema with amlodipine when it's co-prescribed with telmisartan. When we look at classes of antihypertensive drugs in relationship to age and ethnicity, we do notice that there is variation in response to treatment. And an example of this is that older people and Black people have less blood pressure lowering to ACE inhibitors and angiotensin receptor blockers than younger people or Caucasian people. However, if one combines an ACE inhibitor or an angiotensin receptor blocker with a diuretic or a calcium channel blocker, this eliminates the age and ethnic variation. Blacks and whites, older and younger, respond similarly to those combinations. And so fixed dose combinations often have very little age or ethnic variation in response to therapy. The last bullet is also quite important. If we look at a person at a mid-level dose of a drug, and we're considering increasing it to a maximum dose or adding another drug at mid-dose, there's 5 times greater blood pressure reduction from adding the second drug as opposed to titrating to a maximum dose. And so with fixed dose combinations, you tend to get much greater blood pressure reduction at that maximum dose compared to using single drug therapy at higher dose. And again, this may translate to greater, more rapid blood pressure reduction and reduced cardiovascular disease in those clinical trials I alluded to earlier. Next slide. There are some disadvantages to fixed dose combination drugs. It's intuitive that there must be no contraindication or caution for both drug components in the fixed dose combination. There is concerns of higher cost in fixed dose combination drugs, and there are fixed dose combinations that are higher cost. However, when this has been examined in many settings, the fixed dose combinations are the same cost as the individual components, or in many cases, a lower cost. And so this really relates to careful selection of the fixed dose combinations in the protocol. There's a lesser ability to titrate the individual drugs when using fixed dose combinations. Some people use this as an excuse for not using fixed dose combinations, but I personally believe this is overrated. The relationship of drug dose to response is a logarithmic scale, and so you really need a log change in drug dose to double the antihypertensive lowering. And so the small changes that we make clinically in drug doses really make this an overrated concept. There is a problem, though, when patients develop an adverse effect on a fixed dose combination, in that one needs to try to identify which drug it was that caused the problem. Next slide. A variety of national and international recommendations have come out and are increasing the recommendation to use fixed dose combination tablets. The European Society of Cardiology and European Society of Hypertension 2018 guidelines now recommend fixed dose combinations as an option in the initial therapy of hypertension. And they do mention 3 drugs in a tablet as a potential second step. The American Heart Association, American College of Cardiology recommendations indicate fixed dose combinations in initial therapy when blood pressure is 20 on 10 millimeters mercury above its goal. Hypertension Canada was very similar to the AHA, but in the most recent iteration is very similar to the European ones, indicating fixed dose combinations are suitable as an initial therapy of hypertension management, and also recommend that when a patient is on multiple individual tablets, that they can be replaced with fixed dose combination tablets where appropriate. Next slide. One of the most important things is to look at examples of where this has been done very well. Now, the Kaiser Permanente hypertension program in the United States is one of the best examples of this. Mark Joff, who's the senior VP with Resolve to Save Lives, led the Kaiser Permanente program. Kaiser provided great leadership with Mark, but organizationally a high priority to controlling blood pressure. They regularly updated hypertension management recommendations, and most importantly, they translated these recommendations into very simple treatment algorithms, and they also used a fixed dose combination drug. They utilized task sharing and shifting. In particular, they have an office assistant, to measure blood pressure. Patients can come for blood pressure measurements without seeing nurses or physicians to enhance the monitoring of blood pressure. Finally, they have a registry with performance reporting so that each physician and each clinic knows its performance in controlling blood pressure and can take steps to improve how they're controlling blood pressure. Next slide. In the context of this talk, this is the Kaiser Permanente treatment algorithm. Notice on the left, it starts with a ACE inhibitor or thiazide diuretic. The exact drug is specified. It's lisinopril and hydrochlorothiazide. It starts at a half tablet, and if the blood pressure is not controlled, it's titrated to a full tablet and then to 2 tablets. If the person is still not in control, they go to the next step, which is adding amlodipine at 2.5 milligrams a day, increasing to 5 to 10 milligrams a day. Now, these simple 2 steps resulted in markedly enhanced blood pressure control up to 90%, as I'll show in the next slide. Kaiser has further developed the algorithm to put another step in, which is either adding spironolactone or a beta blocker to further control blood pressure. It's important that some people are ACE intolerant or have pregnancy potential. These people are recommended to start their initial therapy with a thiazide diuretic, and they can step forward if they're ACE inhibitor to losartan instead of lisinopril. Quite importantly, this is not a protocol for people who are pregnant, and this protocol requires an assessment of pregnancy potential. Next slide. This slide looks at some of the success of the Kaiser program in relationship to other clinics in the United States. At the start in 2001, the Kaiser program had 44% hypertension control, which was slightly below the national average, which is the green line, in the mid 50% hypertension control. The Kaiser program started around 2003, 2004. And one can see a very rapid acceleration in hypertension control to the mid 70% range, which is really quite high in the international context. But a further increase in control up to 90% control by 2013. The national clinics are actually quite good in the international context. One can see that they really did not change that much and are wavering around the 60% control rate. Next slide. So now that we've really reviewed the Kaiser experience, which I think is one of the global best practices that we should be trying to emulate, Resolve to Save Lives is promoting treatment algorithms or protocols. And they're very simple ones, and there's 2 fundamental ones. The first one suggests using a fixed dose combination. It has the drugs and drug doses specified. The starting tablets that are recommended are amlodipine and telmisartan. The second pill is chlorothalidone. The second protocol does not use fixed dose combinations, but uses the same drugs, amlodipine and telmisartan, and has a third step where chlorothalidone is used. Now, as we've looked at several different settings around the world, telmisartan may not be commonly used or may not be available in an affordable tablet. Many of the countries, chlorothalidone similarly is not commonly used, although these are viewed as some of the best or most ideal treatments. Many countries have substituted those specific drugs for ones that have greater local availability. Next slide. Some observations about programs that have been using treatment algorithms. About half of the programs use amlodipine as a single drug starting, and this is believed likely to avoid the need of laboratory testing and adverse biochemical effects of some of the alternative drugs. many of the projects limit the dose of diuretics, and high-dose diuretics cause hyponatremia and hypokalemia, and it's likely to avoid these biochemical adverse effects and the need for more intensive laboratory testing that diuretic doses are limited. Several of the programs do not yet have a reliable access to a high-quality, affordable fixed-dose combination drugs, and so many of the programs that we've seen have not introduced them. Next slide. In terms of recommendations and treatment protocols, most hypertension guidelines do have algorithms, and I can certainly speak to the Canadian one, that it's very complex and hence very difficult for primary care to implement it to make their decisions easier. The American Heart Association 2017 recommendations do recommend team-based care that includes algorithms but are not specific on what that algorithm should be. Perhaps the most advanced set of recommendations in terms of algorithms are the ESC recommendations that have a simple algorithm, but it does not specify the drug names or drug doses, and so clinics or interventions would need to put those in to guide primary care. Next slide. In terms of some final comments, using fixed-dose combinations provides significant advantages over single drugs and programmatic clinical interventions to control population hypertension. They're not always available, and we certainly have Cuba, where a fixed-dose combination was not available. They started with hydrochlorothiazide and lisinopril as single tablets, but Cuba is now developing a fixed-dose combination tablet, so they will be moving to the fixed-dose combination in the near future. Simple directive algorithms where the drugs and drug doses are specified are a critical component of clinical research, all the randomized controlled trials that were done, and they're very important to primary care interventions to control hypertension. Hypertension interventions supported by HEARTS and Resolve to Save Lives have developed simple directive algorithms, and many of them use fixed-dose combination tablets. HEARTS, sponsored by the WHO and partners, has 7 template algorithms, all of which are very simple with specified drugs and doses. The widespread adoption of these standardized simple protocols with a few select drugs could markedly improve hypertension control rates, but perhaps more important, will allow reliable bulk purchasing of medications with markedly lower costs and higher quality drugs. Next slide. I was asked to provide you some references for further reading. They're on this slide and the subsequent slide to this, and so should be available to you. But I look forward to your questions, and I look forward to the evolution in clinical practice to using fixed-dose combination tablets and simple treatment algorithms. Thank you so much.
And now we'll turn it over to Dr. Carr.
Yeah, sure. Thank you very much. In continuation with discussion on protocols, I'll be sharing with you the experience we had in India in the past 1 year as we went through the process of developing these algorithms in 5 Indian states. Next slide. India Hypertension Control Initiative is a multi-partner project which was launched in November of 2017. The purpose is to strengthen the hypertension treatment component, although we do have a national program for non-communicable disease, but it's a multi-disease program, and there have been multiple interventions introduced. We are yet to achieve our goals and targets in most of the various disease control components. So the idea was to use the core strategies which have been recommended under the WHO HEARTS package. And the project has multiple partners, which include Indian Council of Medical Research, which I represent, and also World Health Organization, Ministry of Health, state governments, and Vital Strategies. Next slide. So after we began the project, the 5 states agreed to participate in the project. And the first step was to conduct protocol consensus meetings. So these meetings were held at provincial or state level, and we planned with the help of the state non-communicable disease cell, which has a nodal officer, and identify who will be the potential participants. So we did 5 consensus meetings, 1 in each of the states. In general, the participant categories included state level officials who work in the non-communicable disease program, the experts or the specialists from the local medical schools, cardiologists, nephrologists, or even physicians. We also had physicians from district hospitals who work at more peripheral level because their perspectives are likely to be different from the physicians who work in medical schools. Few doctors from primary health centers, prominent national experts in medicine, and also the representatives from the partner organizations. Next slide. So it was a half-a-day meeting in most of the states, went on for about 4 hours. We began with overview of India Hypertension Control Initiative, and we presented, after giving the background of what an algorithm is, we presented 3 to 4 algorithm or protocols, which are available in WHO HEARTS package. We had pre-selected these protocols based on discussions with various experts. And then we documented the discussion, and the broad areas of discussion I'll be talking about here. So one of the major topic of discussion was protocol versus guidelines. There was some confusion around that, and it took some time to resolve that confusion in the process of discussions. We also discussed a lot about existing prescription practices and why particular drugs are preferred by doctors in the local context, and a lot of discussion around the different perspectives expressed by clinicians versus public health professionals. Next slide. So the first area of discussion was around need for protocols. Why do we need protocols? And as Professor Campbell mentioned earlier, we all are aware that guidelines are summary of evidence-based practices, and we do have international guidelines, and in India we do have the guidelines issued by Indian professional bodies as well. So many of the experts in the group felt that we really don't need protocols because we already have guidelines. However, as the discussion evolved, we discussed what are the pros and cons of guidelines versus protocols. And most of the doctors who work in the more peripheral setting agreed that the guidelines are very complex. They are usually huge documents, which most doctors at the field level cannot sit and read and interpret. They tend to give many drug classes, many drug options, but the people who have to work in the primary care setting, they would prefer if they have much more specific information. And most of these doctors have worked in the disease control programs in infectious disease, such as tuberculosis, malaria, and therefore they are familiar with the concept of having name of a drug and a fixed dose of a drug, and that makes it just much easier for them. And although the guidelines do provide an overall titration approach, but they do not exactly tell from which dose to which dose after how much period of time and for which drug. And this creates a lot of confusion for those who are practicing in the primary care setting. They find it very hard to make decisions, and quite often what they do is they end up referring a large number of patients to either a secondary care or to a tertiary care institution, which means there are a lot of dropouts, and the patients quite often do not go to higher level facilities. There was also a lot of discussion around how feasible it is to use guidelines in the primary care settings, because we do understand that scale is one of the biggest problems in public health setting. We are often dealing with very large number of patients. In India, the district hospitals are very crowded and they see 500 to 1,000 patients in a day, and it's extremely difficult for doctors to implement complex guidelines. Next slide. So this is just a sample protocol, and I'll be talking more about it, but just to give you a sense of what we were able to arrive at the end of these meetings. And in most of the states, we had very similar protocol. This is from one of the northern states in India, where we were able to agree upon 3 drugs, amlodipine, telmisartan, and chlorthalidone. I'll be talking a little more about it in the subsequent slides. Next slide. One of the major area of discussion in these meetings was the difference of perspectives. The clinicians had very different perspective as compared to the public health managers. Most clinicians felt that they should not be limited or restricted in terms of what type of drugs are made available in the institutions. But this perspective was more among doctors who came from the medical schools. However, on the contrary, we don't have hypertension drugs available in adequate quantities in most institutions at the peripheral level. And therefore, public health managers felt that it's a huge challenge for them to procure variety of drugs and ensure availability of adequate quantities. And therefore, they would prefer if they are given name of 2 or 3 drugs, and it will enable them to procure, do a better forecasting and procurement in time. The other concern which was discussed by all the participants was around side effects. They all felt that we don't have laboratory setup and we don't have ability to monitor the side effects. Therefore, we need to be very careful about which drugs we choose in our protocol. And there was concern about exceptions, but I think everybody agreed that as long as we can treat 90% of the patient, a small proportion can be referred to the higher level institutions. And a lot of discussion about trying to reach higher coverage. As you know, India, we have about 200 million people with hypertension. And how do we ensure that a large proportion of them are able to get treatment, at least 1 or 2 drugs? Because access to treatment is more important than the type of drug. In general, there was low awareness about therapeutic inertia, and except for few physicians, they felt that doctors do a good job of treating hypertension. And the public health community was very concerned about the high cost of drugs, and therefore they pleaded that we need to invest more in terms of ensuring availability of free drugs in the primary care institutions. Next slide. So the consensus was around these 3 drugs, and as Professor Campbell mentioned earlier, I think amlodipine was preferred. Although there's few protocols which are available in hearts and also in other settings which start with ARBs or AC inhibitors, but in India, most doctors felt that we cannot monitor creatinine and potassium for all the patients, and we cannot test that prior to initiating the treatment, and therefore the first drug should be amlodipine. 2 options were considered. In few states, experts felt that amlodipine should be increased from 5 to 10, and then the second drug should be added. However, in other settings, they felt that after 5 milligram amlodipine, we should move to telmi and then increase the dose of amlo. There was a lot of discussion around challenge of diagnostics, inability to do the lab testing, and specifically as far as diuretics are concerned, there was also concerns that a lot of doctors in India don't want to prescribe because they feel that patients work in hot environments, and therefore they feel more tired and they tend to get dehydrated. Next slide. So there were many areas which were discussed, and I've just listed a few here. There were challenges in agreeing on the concept of choosing a specific drug versus a class. Most experts felt we should only mention a class. And then there was a bigger discussion around how do we ensure that we have diagnosed our hypertension correctly, how many readings is right, which BP monitor should be used, and should we call the patient back, how many times, will the patient come back? So a lot of discussion around that. There was also lack of clarity regarding role of lifestyle modification. There is a group of doctors who feel that there should be 2 or 3 month trial of lifestyle modification, whereas others felt that most of the patients are unable to do any lifestyle changes, and therefore we need to be more aggressive in initiating medications. And we also have a huge challenge of task sharing. India is in the early stage of setting up what we call as health and wellness centers, which will be run by a nurse equivalent who will be able to dispense the drugs, however not able to prescribe the drug, which means that we need to ensure that the patient are prescribed and their blood pressure is controlled, and then we could refer them to more peripheral facilities where the drugs could be dispensed. However, this is in very early stages of implementation, and this stage we don't have very clear answers how successful this initiative will be. Next slide. So just to sum it up, we were able to reach consensus in certain areas. Most doctors felt that if the BP is more than 140/90 but below 160/100, patient can be asked to come second time. Some of them felt that a trial of lifestyle modification should be considered. However, above 160/100, there was a general agreement that the treatment should be initiated after doing another reading the same day. In all the 5 states, experts agreed on 3 drugs. Although chlorthalidone, they all felt that procurement will be a challenge in initial year because most of the states did not have any rate contracts. The 2-dose titration approach, as I mentioned earlier, few states picked the first and few picked the second approach. And there was also initially a lot of discussion because we had agreed that the change will be after 1 month, going from AMLO 5 to AMLO 10. But then many doctors felt that patients who have higher grades of blood pressure should be asked to visit more often, and therefore we added this as a footnote in the protocol as well. So thank you very much. I'll stop with this and we'll be open to answer more questions. Thanks.
Thank you both for an excellent presentation. We'll now open up for Q&A. As a reminder, we encourage you to use the Q&A button to ask questions, which is located at the bottom of your screen. Participants will now be unmuted, and this webinar will be recorded and posted to the LINCS website.
And while we're waiting for questions, this is Tom Frieden. I just wanted to go through some of the questions and some of the points that we heard. But really striking that we have learned that there is really a global consensus on these 3 drugs or 3 classes, and if price and access are no barrier, the 3 drugs seem to be sifting to the top as a coalescing consensus if procurement issues can be addressed. The very strong sense of the importance of minimizing adverse effects is something that we've heard loud and clear. And Dr. Mark Jassy is sitting next to me here and reminds us always that the best protocol is the protocol that gets followed. So going to the first question that we have in our system, what are the main obstacles to the use of a simple protocol? Are we changing health and medical education to help make these changes among those early in their careers? Either of you want to take that on?
Maybe I can start, Tom, and then maybe Pradeep can give the final answer. I think many of us have been taught in medical school that it's important to individualize therapy regardless of the therapeutic area. Look at the patient characteristics and then select the appropriate therapy. And this has resulted in problems. When we started antihypertensive therapy with stepped care, it started with a diuretic, then a beta blocker was added, then a vasodilator was added as the 3rd step. In Canada, that was noticed to result in reasonable blood pressure control. With the development of newer therapies, there was heavy marketing and education to individualize the therapy, typically to these newer therapies. And what we noticed was that blood pressure control went down because there was confusion over what the subsequent steps were, and that the costs went up. But I think it's this very strong education that goes right across many therapeutic areas to individualize the therapy. And I think that has undermined what we know from clinical trials and evidence that these protocols, simple directed protocols, result in much greater therapeutic outcomes at reduced cost.
Great. Dr. Kaur, do you want to add anything to that?
Yeah, just one thing I would like to add, that we find that there's very low awareness among doctors that they are the reasons behind low control. So quite often they think they are treating right. So we find that's one of the major challenges. So we need to really educate and re-educate, and it seems like we have to do it over a long period of time. And the second challenge in Indian context we have sometimes is availability of drugs, because we are working on that. We are working with governments to improve the availability, but quite often the drug which is in the protocol is not available, and therefore doctors end up prescribing something else. Thank you.
Thank you. One of the other questions that often arises is why beta blockers are not recommended by most guidelines and by country protocols. This is something that comes up in many of the consensus conferences and questions that we hear. Dr. Campbell?
Thanks, Tom. I think there's several different reasons for that. One, beta blockers do not lower blood pressure equally in all groups. They have less effectiveness in Black people and older people. They have a side effect profile that can be undesirable, particularly in higher doses. And in clinical trials, they appear to be less effective at reducing stroke than other classes of antihypertensive medications. For those reasons, they're not typically recommended in drug protocols or as initial therapy.
Dr. Kaur, do you want to add anything to that?
Yeah, it's a very big challenge for us because atenolol is the most commonly prescribed drug in most Indian states. And when we did these protocol consensus meetings, many doctors did raise that why we are not keeping atenolol, which is there in the supply and be given to a large number of patients. Although it did happen that during the discussion, most physicians agreed that beta blockers are no more first line, and therefore we were able to arrive consensus. Thank you.
All right. Here's the next question through the chat. The concern is for the accuracy of blood pressure measurement. The question is to comment on the likelihood that many people may have been put on treatment for hypertension because of inaccurate measurements, blood pressure not being measured correctly.
I can start, and Pradeep can give the final answer if that helps. I think it is a substantive concern, but the main concern that we have globally is that hypertension is not being diagnosed, treated, and controlled, and that's resulting in 10 million unnecessary deaths. And so I would suggest that the greatest priority is screening and diagnosing and controlling hypertension. Now, when blood pressure is measured inappropriately or by lack of standardized techniques, it generally results in a false high reading, and so that can result in more people being treated. But when we look globally, that's not the issue, the main issue that we face. There are several different groups, including groups that I represent, that are trying to get standardized training programs and even certification for healthcare professionals to measure blood pressure, and strongly advocating regulations so that only validated, accurate devices can be sold globally. So I certainly agree steps need to be taken to improve accuracy, but right now the major problem is lack of treatment as opposed to over-treatment.
Dr. Kaur?
Yeah, we acknowledge this is an issue, and that's why, as part of the project, Resolve to Save Lives have provided BP monitors, 5 professional standard BP monitors, and all the health facility implementing the program. However, I agree that under-treatment is a much bigger problem for us, because in India we have the awareness, people who are aware of their hypertension status is only 25 to 50%. Variable across states, and only 1 in 10 have their BP controlled. So we did hear this in the consensus meetings, that whether we are over-treating, and that's the reason, as you can see, there's a footnote in the protocol that most doctors felt that those patients who have below 160/100 should have a second visit, and only then the treatment should be initiated. Thank you.
Thank you. And I would also comment that we have a very simple graphic giving guidance on blood pressure measurement, which we can post on the links cite. Also, as we understand more that lower is better, we recognize, although we have not yet changed global policy to 130 or 120 as a desirable or a treatment goal, that we're not harming people if we're over-treating by and large. We're actually possibly providing them with some benefit, although the number needed to treat to achieve that benefit may be relatively large. The next question relates to diet and lifestyle management. Role do they have vis-a-vis medications? Would each of you like to comment?
I guess I'll start that. I'm a very strong believer in lifestyle management. I'm trying to prevent hypertension in myself personally by trying to follow a healthy lifestyle. In settings where people follow healthy lifestyle or follow those recommendations, they are very effective at lowering blood pressure and can prevent hypertension when implemented on a population basis. The weakness really relates to the lack of ability of people to follow healthy lifestyle advice, particularly in the context of unhealthy environments that don't support healthy choices. So that in randomized controlled trials, we can demonstrate that it's about twice as likely a person will follow a healthy lifestyle when it's recommended. That is a result of 2% of people spontaneously changing. After the advice, it goes up to 4%, so 96% fail. That comes back to a recommendation that I make is we should not delay drug therapy to implement lifestyle recommendations because about 96% of people will fail those recommendations. What we're really doing is deferring a treatment that prevents cardiovascular events, and a number of people will have unnecessary cardiovascular events if drug therapy is delayed.
Dr. Kaur?
This is extensively discussed in most of the meetings. The challenge we have in our setting is that a lot of our population is rural and have limited understanding how to implement lifestyle modification in their environments. They have limited food choices, and most of the time food is cooked for the family at home, and therefore extremely difficult to individualize the diets. But interestingly, when we do patient surveys, we find that 70% of the patients report that they have tried to reduce salt. But most of these settings, we see that we haven't been able to see blood pressure control among those patients, which implies that the level of modification required to achieve blood pressure reduction is not feasible for majority of the patients. Thank you.
Thank you. This is Tom Frieden. I'll make two other comments about this. Lifestyle modification is probably best done on a societal basis so that we reduce, for example, the amount of sodium in food or make environments more walkable or bicyclable. This is more likely to have a mass effect than encouraging individual patients to change. The other comment to make is that even if we are wildly successful with lifestyle modification, there will be 1 billion people in the world who need treatment of hypertension. So it's not an either or, and we know that patients who do increase physical activity and reduce weight and reduce sodium intake and improve their nutritional profile can reduce their blood pressure, and that this can be synergistic with medications. But it would be, I think, a disservice to patients to rely on lifestyle modification when medications not only are necessary, but have been the standard of care for more than half a century in the wealthier world. The next question is as follows. Monitoring adherence through follow-up is a key piece of ascertaining success of treatment, but follow-up rates are often a challenge. Appreciate thoughts on successful strategies to improve follow-up rates observed to date in these interventions or being planned.
Okay, well, I'll follow the sequence. I would agree lack of adherence to follow-up and lack of adherence to antihypertensive therapy is a major challenge. We often relate these to patient characteristics, but in many cases it relates to the healthcare professional-patient relationship as opposed to just a patient characteristic. And it's resolvable by healthcare professionals. And so one of the first things is educating the patient about the critical importance of hypertension as a determinant of how they're going to do death in terms of death and disability. They also need to know the great importance of adhering to their therapy to achieve its benefit at the target levels. So a well-informed patient is important. Ensuring that the treatments are affordable to the patient, accessible to the patient, is also of great importance. And then taking the follow-up and treatment in terms of the patient's context. If a patient can't come back in a month, giving them a month's worth of antihypertensive drugs and telling them to come back then will result in non-adherence. So understanding what the patient's circumstances are. If they can't come back for 2 months, make sure they have more than 2 months of therapy so that they will come back. They will be able to adhere to their therapy. And I think those are probably the key components. There are other aspects such as interdisciplinary care, telephone contact with the patient shortly after taking their therapy to make sure they're having no problems or don't have questions that might interfere with adherence. Long-acting, once-a-day therapies with low side effect profiles, etc., are also of great importance.
Dr. Ford, you want to add anything on that?
Yeah, just two things. In India project, we do have a focus on a cohort approach. So we do have in all the clinics implementing this project, collect the phone number and address of the patient. And the two strategies which are being tried is one is reminding the patient through phone calls, and second is linkages with the peripheral health worker called ASHA and ANM in Indian context. So they would be facilitating the follow-up. And in addition, Resolve to Save Lives is also introduced an app which is being pilot tested, which is also helping us work on the follow-up component. Thank you.
I would just add that perhaps one of the crucial aspects, in addition to reducing barriers to patients and task sharing so that people closer to patients can be providing support, is the availability of data on how facilities are doing. And what we find globally is that when facilities can see their data and have a register of patients to call back, there's a substantial improvement in outcomes. Generally, we find that providers vastly overestimate what their control rates are when they guess, and when you see the control rates, they're actually much lower, and when they see the control rates, they figure out ways to improve them from inside of their practice. There are two other questions or comments. One, can we have these presentations for use and training purposes? And yes, they will be posted on the Links website, and thank you all for joining linkscommunity.org. We encourage you to both use it and to encourage others to join. And second, can we share some experiences, if any, on implementation of FDCs in HEART's protocols? And I think we have not yet found any international global group using an FDC. The issue has been that they have not yet been added to the World Health Organization Essential Medicines list. Resolve to Save Lives, along with several of our partners, have submitted an application that will be considered this April and May to have them included, and we should know by the end of May whether that is the case, and we hope that will result in both the uptake of FDCs and the standardization and decrease in price of FDCs. Dr. Jaffe, perhaps you want to mention this from your experience at Kaiser or elsewhere.
Yes. So clearly, FDCs play a role, and the experience in a high-income country at Kaiser Permanente may or may not be similar to the experiences that we'll have in a setting where there may be reduced access to medication. I do think that what's important is that, as Dr. Campbell mentioned, for those patients who are on more than one medication, which is most patients, that there be a consideration that FDCs be used. So we're really looking forward to a location such as, I know Dr. Campbell mentioned Cuba and some of the Latin American countries, where there is an interest in moving forward with an FDC at the start, and that may require more access to laboratory testing than is currently available. So right now it's currently an option, and we're looking forward to looking for a site that's going to be showing us how to do this in a low and middle income setting.
Great. And the two FDCs we're looking at globally are telmisartan amlodipine and telmisartan chlorthalidone as possible optimal FDCs. This concludes our 1-hour webinar. Thank you so much to Norm Campbell and Prabir Kaur for superb presentations, to our listeners for being here, and to the people who raised great questions for enriching the discussion. And we will be in touch next month. All the best.
Thank you very much.
Bye.